You ready? Yeah. Good morning, everybody. This is a very special grand rounds that we have this morning. And it actually came about because of discussions that I've had with Dr. Hansen. I know he's here over the years, where we had talked about some of the persistent myths that have been around in orthopedics for decades. And he had talked about why not have a series of grand rounds where some of the quote-unquote old-timers could get together and sort of demolish some of those myths, but also talk about how some of our current accepted practices came into being. And so it's taken a few years, but we finally got around to it. We have some special visitors today. And for people out there that think they may have been excluded, some of our wise men, other wise men and women that have been around for perhaps decades in the area, we have a few more of these planned, so we may be calling on you to help us out in the future. So a couple of announcements. We have accolades for Kenny Gundel, and this is from Harborview, and the patient stated that Dr. Kenny G. was a pleasure to meet. She believed he is with the orthopedic team, which, Kenny, I think that's true. And she also went on to praise Daphne Beingessner for her excellent care. And then also from Harborview, patient seen in the ED stated that Ahmad Bayomi was very good and did what needed to be done really quickly and with as little pain as possible. He spoke with me and sat and joked with me and made me feel a lot more comfortable. So thank you, Ahmad. And then one other announcement. I think Bruce is here, Sanjosan. Bruce was made the president-elect of the American Orthopedic Foot and Ankle Society, which of course is a great honor. And Bruce will ask you after grand rounds if that means you're going to be admitting podiatrists into that organization. We will start our grand rounds now, and it's going to be hosted by Dane Mickelson.
Thank you, Dr. Jansky. Welcome, everybody. I'd like to say that this really is a special grand rounds. We've been really looking forward to this for a while. Just to start, I wanted to kind of explain how we got here, and see if this works. Moving. There we go. So I was tasked with starting grand rounds and setting it up with Dr. Chansky this year, and we're really excited about what we have planned. We've got a number of topics, both highlighting new faculty and also a number of orthopedic concepts. We've had some visiting lectures that are planned and coming up. We had the Garrick lecturers talk this past month, and we have Dr. Burt Yazzie from Grady's Children's Hospital in San Diego that will be joining us in December, as well as Dr. Greg Nicandri, who will be visiting us in June. Both of them are accomplished UW Orthopedic residency alumni. So we're really excited about that. But this morning was something that personally I was most excited about. I think this is a really unique opportunity, something we hope to move forward with. When we sat down to plan this year, as Dr. Chansky had mentioned, there was this need and want for us to kind of bring back some of the senior people in our area in the orthopedic specialty. And so I think this morning is really a celebration of the past and its intersection and relevance to the present and the future, and probably most summarized by Carl Sagan. He's an astrophysicist, and he says that you have to know the past to understand the present. And looking through, we realized that there is just an immense amount of knowledge of the past and stories and wisdom among the senior members of our orthopedic specialty, and we wanted to really harness that this morning. And so we came up with what we're calling the Three Wise Men lecture. It could also be the Three Wise Women. It could be, I guess to be politically correct, the Three Wise People. We wanted to basically bring in three of our senior members, try to see if they can condense this small talk down to about 15 minutes. And we'll see. Hopefully they've got so much knowledge it's probably going to be overwhelming the room. But to then provide that to us and give us some lessons, some stories, some anecdotes, and hopefully some great pictures from the past. And this morning, as the inaugural one, we're going to actually celebrate 3 of our own alumni. And so we're really happy about that. And so this morning, I'd like to welcome you to the first 3 Wise Men lecture. We call it the Stories, Advice, and Wisdom from My Time in Orthopedics. And this is something we're hoping to have on an annual basis because there's a number of people we want to bring back in. And so to start, Dr. Toomey is going to speak about Sir John Charnley and the start of it all, followed by Dr. Hansen, who's going to talk about pioneering intramedullary nails in the modern orthopedic trauma center. And to wrap it up, Dr. Wagner is going to talk about footsteps in spine surgery. So to start, Dr. Toomey, he's born in Visalia, California, went to college at WSU, which we don't hold against him. He was in the infantry in the 50s, and then went to medical school and residency here at the University of Washington. He had a prolific career here in Seattle. He was part of the orthopedic physicians at Swedish, at Providence. He worked at Children's as well. And he really was a pioneer of total hip reconstruction and osteotomies around the Seattle area when it was just starting out. He was a consultant for sports teams in the area. He was also a clinical professor of orthopedics at the University School of Medicine and a consultant for Harborview Medical Center during his time. He enjoys the outdoors. This is a picture from him in the 80s on Mount Everest. And hiking here, actually, with one of our other wise men here in the center. That's Dr. Wagner, and there's Dr. Toomey. And so I'd like to introduce Dr. Toomey to come on up and start off our wise men lecture.
Thank you. That's premature. I wonder if the definition of 3 wise men really means they've made all the mistakes and learned a little bit from them. Sir, I had initially I had planned to talk about the mistakes in the context of you can't, if you don't know history, you're bound to repeat the mistakes of history. But after I had about 120 slides of bad designs in hip implants, I changed the topic to talking about the historical aspects of John Charnley, Sir John Charnley, who was born at an age that put him into the First World War, so he got through medical school before he was into the military. He served in Dunkirk, finished up in Cairo, and only after then did he go into the orthopedic track. He was a inquisitive, scientific sort of a guy to the point that he had a fellow resident do a bone graft experimental procedure on his leg, which got infected, which caused some trouble. He later injected subcutaneously in himself some ground-up polyethylene to see what the effect might be. His career was at Wrightington near Wigan near Liverpool, and I chose those words because when I went to visit Charnley in '69, my directions were at Wrightington near Wigan. Well, you got to be Brit to know how to follow those directions, but I found a map and found out it was close to Liverpool, so I knew where to fly to. And then I got on a bus to go out to Wrightington, and I reckon since it's 25 miles, I would make the 9:30 clinic by taking the bus and seeing the countryside. Well, I didn't know that the public buses were also school buses. After 50 stops, I was half hour late for the clinic. And in his clinic, which he had every 2 weeks, there was probably 20 or 30 visitors there. Everybody had to be in a white coat because patients were coming in and out of the room. And so Dick Welch, who was an American fellow with Charnley at that time and had a long career in San Francisco, came back to put a white coat on me, and he tried to put it on me over my suit coat, and it wouldn't fit, so we took that off and took the suit coat off, put the white coat on, and by then everybody in the room knew that another American had arrived. Wrightington today looks like that. However, it didn't look like that when I visited. It was kind of more like an old army barracks, and the operating room was an old house that had been remodeled. Charnley was a hands-on guy who understood the biomechanics of things, understood machining and machining problems, and did a lot of his work in the attic of his house where his engineer was housed early on. He was prompt to let you know that if you weren't a student of tribology, you had no business doing hips. Tribology being the study of friction, lubrication, and wear related to moving objects one on the other. And Da Vinci laid out before the concept that the relationship of friction had to do with weight, and when you double the weight, you double the force required to move one object on the other. He found in his lab that weight interface is not very important, so he focused on the interaction of the dry materials, developing the low friction arthroplasty, and it was known universally as the LFA, using the small ball as the least amount of friction, even though he recognized it was the least stable of the options as well. Friction has to do with asperities on the surfaces, so even though a nice, smoothly polished, round spherical head on a hip implant has asperities which would look a little bit like that, and under under the upper slide showing no load, and then the lower slide showing the loaded grinding away of the points of the asperities, leading to the debris generated in a hip joint. Upper suite was the old house, as mentioned, and he recognized an unacceptable infection rate early on, and I believe that Dr. Clausen had been over there, and he could kind of get a shaking, tremulous head when he pointed out a 20 or 30% infection rate was what you accepted if you set out to do these artificial hips. But this led Charnley to push on the issue, and he pursued it as you see above. And the interesting thing that when he added breath exhausts inside his operating helmets, he called them, it had no benefit, and he dropped his infection rate another 1 or 2% by adding the body exhaust aspects of his spacesuits. He abandoned Teflon, as you see, about 58, and was 3 years in the doldrums, and then during which time he personally revised all failures, and I don't know what he revised them to. In any event, he started using high-density polyethylene in '61. Because of his bad experience and bad rap for the Teflon experience, he was very quiet and almost secretive, and for 5 years of experience before he went public. The early masks were a little bit of a hindrance to visibility, and he was an elfin little guy who looked almost comedic in his getup. His instruments he designed himself, and the early version had no cement restrictor. I don't know why I can't work this. The restrictor on the top didn't exist for the first 4 or 5 years, and it is said that he pushed these fingers of cement through his pilot hole to an extent that all the American visitors got excited and told him he shouldn't be doing that, that he added that cement restrictor to keep the intrusion of the cement intrapelvic quite so far. His cups had a skirt on them that helped contain the cement in the acetabulum and help the pressurization that he sought. The inserting handle, you see, fixed to the insert in a straight line, so that one had to have the trochanter out of the way in order to insert this thing. The cup down here snapped into the inserter like this. The straight handle with all of his jig, and since he had the patients flat on their back, he could set his anteversion and his abduction quite consistently in doing his cases. He had an aggressive retrieval program, so the patients had to agree up front, preoperatively, that they'd allow the hip to be extracted at postmortem for study. And then remarkable that he could grind his own cups and his own poly. And Factory was his chief engineering collaborator who ultimately took over the manufacture and marketing of this issue. And he's the big proponent to tout that cement is not a cement. It's not a glue. It's not going to stick things together. It's purely a grout. Part of his ascendancy was having to do with a little serendipity when a German manufacturer sales rep came by with a specimen of improved plastic. Charnley was so negative about plastic, he says, "I have no interest, go." And the guy left it on the corner of his desk, the story goes. And this fella, Harry Craven, his engineer, came by, says, "What's this?" Charnley says, "It's a piece of plastic, throw it away." And instead, Craven ran it on his wear machine, and lo and behold, was 1,000 times better than Teflon, which did catch Charnley's attention. The wear machine was not a very sophisticated deal, and in America now, a wear machine has elliptical processes and has those irrigating solutions and this and that. His was purely a plate on which the plastic was rubbed back and forth, to and fro, and only had a 2 or 3 inch excursion. But he reckoned after 2 days of that, it was equivalent of a year's wear in situ. So he was off and running due to the persistence of this guy. He kind of took a beating from Charnley in the terms of it being demanded that he build this and build that. He had no funds, no money. He was working in Charnley's attic, but he did. And the gentlemanly demeanor of Charnley was characterized by this. He was a young house officer at the time and was stunned to find these niceties laid out for him when he arrived. Hugh Holworth was a air conditioning guy who Charnley called to get a consult. He wanted to build this laminar flow type room, although it wasn't called laminar flow at that time. Holworth says something like child's play. And Charnley took umbrage at that. He said, this is a complex issue. You don't understand. He says, you don't understand. I do air conditioning in breweries. I have to have clean air. They are 20 yards by 40 yards by 4 stories high. I can handle a 10 by 10 by 8 little project. Charnley still wasn't convinced, so ultimately Holworth says, I'll give you one. So he gave him his prototype model, and there it went. I mentioned Charnley was secretive about what he was doing, and the scrub nurse's job was to get anything off the table that was still under development out of sight of the visitors. He was a big advocate of wound compression via an array of pre-made bolsters, as you see, and that's an ugly slide that I snipped out of a video, but those are big cotton balls that were prepared on the table in the set, and he put in big retention sutures, and he had a snap arrangement on either end, so he didn't tie knots on these things, just squeezed the clip and he was done. His surgical technique was radically different than imposed upon the U.S. by particularly those who are advocates of the cup arthroplasty in years before, in which a complete debridement capsulectomy was felt to be a, quote, mandatory part of any hip reconstruction. He didn't take anything out. He did a minimal poking from front to the back of the abductors, whacked it off the trochanter, turned it upstream, didn't do much freeing anterior or posteriorly, so it really was not very good exposure. When he wanted to view the anterior aspect of the acetabulum he's working on, he would stick a big elevator, a shiny, clean elevator in there, and look at the reflection. And that's all he had by way of visibility of the anterior half of the acetabulum. The Charnley retractor, which we've used forever, dawned on me as I was doing the slides that we never use it the way it was determined. And the chain you see, he was working with the patient's flat on the back, as I mentioned, so that the anterior aspect of the wound was in the way. And he put the clip hook in the front of the wound, and then he hooked the chain into that hole on the top you see, and then he threw this bigger weight over the patient, and that tilted the retractor and tissues up out of his way. And that retractor's, I think, never used with a weight on it, but is used regularly still in our armamentarium. His first house looked like that. When I was there, there was a glass wall, so this was must be the prototype, and there was a glass wall on the side, and over here on either side, depending on where the action was, there was 3 little mini a ladder or stairs, so you could take 8 or 10 or 12 perhaps visitors, and they could stand in there and watch and get nowhere near the wound. This was the Teflon then was the big problem of it all, but at the same time it proved the proof of concept. That peg on the end up there is where he put his initial pilot hole, and then in this phase of his development stuck that into the pilot hole. That came off of the cups, and he still did his pilot hole and let the cement go through, but and then the restrictors then started limiting how much that did. I wanted to introduce another character. That's Maurice Muller, who, of course, is the father of the AO system, and this was his implant. The two were good friends. They went skiing together, but Charnley had no regard for his implant. He thought it was all wrong. This was very easy to insert and was very popular, and I used it a lot, to my mistake. And it was kind of like sliding a banana down the down the femur once you had prepared the way. And it was easy to get in varus. It had a sharp medial edge, which meant it tended to cut through medially, and lo and behold, they did. This is a bad artist, bad demonstration of a point. Actually, the Muller came to maybe 3 millimeter margin on the tip, while Charnley was maybe 8 millimeters. But that's the concept of one being much more cutting than the other. And the typical failure pattern sees it falling into varus with an opening gap on the lateral shoulder. The concept then, here is a proper Charnley on the left with a trochanter transferred, good fixation, hypertrophy of the stem where the stressors are being transferred, a good thick cup cement mantle, the intrusion of the cement through the pilot hole, and you would love that one. 2 years later, this was done and got Americanized. They didn't take the trochanter off, but nevertheless, still a good-looking implant. And I'm wondering if the one on the left was CMW and the one on the right was simplex cement. See the thinner acetabular cement wall, and I think there had to be something with the stiffness of the cement he was using, staying put and not running out around the edges. On the left is a Robin Ling prosthesis. It was a very good prosthesis. It didn't gain much traction in this country, but he added a different concept of the cement, so it had to be tapered, medial, lateral, anterior, posterior, all the way down, and then down here you see a gap. He believed that they would all subside. They must be allowed to subside. They should be designed to subside. And he had a little plastic cup down there so it could. And he thought a good hip would have a couple millimeters of subsidence without end loading the cement down here. And indeed, at Charnley's clinic, I saw several with fractures of the cement across there, indicating end loading and pushing down the tip of the cement plug. Our armamentarium was very limited. Charnley on the left going through Mueller, then a T-28 was out of Iowa, and then the two on the right are out of Boston, where Bill Harris was the only one whose lab seemed to show that loading the Calcar was an important thing to do, and he demonstrated 40% better retention of Calcar bone if doing that, but nevertheless it never dominated our scene. The instruments were a bit crude. Everything was monoblock, and a typical Charnley that we won't talk about. We've been over that, and thank you.
Thanks, Dr. Toomey. That was great. Next up this morning will be Dr. Hansen. Dr. Hansen, you all are familiar with. He's what people call the father of modern traumatology, whose innovations in aggressive and swift orthopedic care of polytrauma patients has really revolutionized the field. He started out in Spokane, Washington as a farm boy. This is back from 1945. This is an article in the newspaper right before he started medical school, some research he was doing, actually through the University Department of Physiology. I think it was testing blood fat, if I don't remember correctly. He went to college at Whitman, went to medical school here at the University of Washington, did his internship, which was then called the King County Hospital, and his residency here at the University of Washington as well. He then spent a while as a lieutenant in the U.S. Navy from 62 to 65. Did some postgraduate work both at UCLA doing prosthetics for a month, and then pediatric orthopedics in England. His career spans over 6 decades. Here at the University of Washington, he's professor emeritus, a chairman emeritus. He's worked at Harborview Children's and the University of Washington Medical Center, where he held positions as the chief of orthopedics, the director of a medical director, and also the director of the Foot and Ankle Institute, which was named after him. He retired in 2011, but has gained a number of accolades. That includes the Harborview Medical Center Mission of Caring Award, AO Foundation Innovation Prize, the University School of Medicine Distinguished Alumnus Award, and most recently, the AOA Distinguished Contributions to Orthopedics Award. So I'd like to invite Dr. Hansen up here.
That makes me feel older than I already was feeling. Been a long tour here. What I would like to do is talk to you a little bit, or I thought working with Dane, we thought it would be fun to talk about how we started the closed intramedullary nailing program, and then how it affected, or how it was related to the beginning of a trauma center, which means that we'll talk a little bit about COPUS and the paramedics. You didn't tell me how to work this exactly. I guess that's it. I was just thinking it was nice to have this little promo in the Seattle Times this weekend about talking about Harborview. But anyway, we'll go on and first talk about how we started doing the IM nailing. Dr. Clausen, in 1965, had been here for about 5 or 6 years as the head of orthopedics, but it was a division of surgery. In 65, he changed it. Somehow he got it away from surgery and became a department. So we've been a department as caused by Dr. Clausen since 1965. In the same year, he invited Gerhard Kuntscher to come and visit, and that's the year that Pete and I were our first-year residents in orthopedics in 1965. And so we heard him, and were duly impressed, or at least I was. Clausen then soon ordered all the special equipment, power reamers, all the various things that you know, but some you don't know. The way they used to do this technique is you put a pin through the tibia when the patient first came in, and then you put a pin through the iliac crest. and then you put on a U-bolt distractor and you left the patient in traction in this sort of torture device for a week or so before you nailed their femur. Anyway, all that stuff was on site, and then we waited because Clausen wasn't going to let anybody touch a patient until somebody went to actually visit with Kuncher and see how he did this technique, and then we were allowed to do it. And the person who did that was Bob Smith, who unfortunately was one of the only pictures I couldn't find that I really wanted to get. But he was a big guy who was kind of eager and a little bit rough, and he was known as, when he was the chief resident at Harborview, and in those days we can all remember here that there was a single chief resident at Harborview, and attendings weren't too involved at first. And, Bob was called Captain Crunch, and so for a while then all of us as the first chief residents at Harborview were just known that was Captain Crunch. That was the chief resident at Harborview. But anyway, he went to work with Kuncher and came back and did 3 or 4 IM nailings, and I was assigned to be his assistant and learn how to do that because it was known he was going to leave and go into practice in Bellingham, which he did. And then I was on my own, literally. And the reason for that was Dr. Clausen had developed a Richards sliding screw for IT fractures in the elderly, and was convinced of getting the patients, getting old patients fixed and out of bed was what made them survive and what made them actually stay functional. And he, so he's had this motivation to get the IM nailing, I think he saw as an extension to younger people of the same philosophy he had with intertrochanteric fractures. But by this time, he was primarily a hand surgeon. He'd done his fellowship in England with, who was that guy? Anyway, he'd done a fellowship basically in hand surgery, and he learned a little bit about the sliding screws came from Europe as well. But he was more of an administrator and teacher, and as you know, he went on, he left here to be a dean. And he was doing that sort of thing. It virtually never came to the operating room when I was a resident. All the other faculty not only didn't come to the operating room with that, they prevented their residents from coming, and they thought I was committing malpractice by nailing femurs. And so the only help I had, no other residents, no other faculty, here's my helper. Some of you in the room know this guy very well. He's the best helper you could possibly have. Ivory Larry was our outstanding orthopedic physician's assistant, and he would run this very complex equipment, the Ossimat reamers and all this stuff, and manipulate the leg while I nailed the femurs in the first time. Then I went to visit Kuncher as well in 1970 when I was doing a fellowship in England, and this was a picture that I took of him at that time. You couldn't get him out of the operating room. He was single still. He'd never been married. The only thing he was really fond of was his car. Now you'd think he must have had a beautiful Mercedes, but no, he had a Jaguar. And he used to love to drive his Jaguar and then spend the rest of his time, virtually his entire life. He died only 2 years after this. He was wandering around the operating room trying to figure out how to nail the spine, interestingly, Ted. He never figured that out, but he did nail a lot of other things that he shouldn't have nailed, but in the femur it was great. Sorry, this is Kuncher. And then what is it all about, this nailing of the femur? People thought that, everybody told us that, you don't need to do that, it's all this risk, fractures heal, you don't need to heal the fractures by putting a nail in them. And what I learned a little bit from Clausen, and my feeling was that nailing fractures of this type was not just about healing the fracture. It was to prevent this situation you saw in severely injured patients, which I dubbed horizontal crucifixion. This where people have maybe a couple fractures, they're in traction, they've got lines in their arms, they've got tubes in their chest, and people didn't survive this at a real high rate. And I thought that's what I wanted to resolve. How could we get out of that problem? And we had an early test in 1968 before there were paramedics. Some of you have heard me talk about this, but I keep remembering that you keep cycling, so many of you haven't. We talk about, sorry, I see it over here, this is what I was talking about. Horizontal crucifixion is this position that we mentioned. And the example of that came in 1968 when I was a chief resident, and my attending was Thomas Taylor, who had been trained in Europe. He was very conservative. He thought that I shouldn't be in the program because I had come out of the Navy where I'd never been in a hospital for 3 years. And he thought that for a proper orthopedic resident, you should not only take an internship, but you should take a year of general surgery and then you could come and be an orthopedic resident. I'd done none of the same. And I didn't get back till August, so I was late. And he didn't want me there from the beginning. And that was kind of interesting because I had never in my life experienced somebody that was giving me nothing but crap all the time. That had never happened before, so it was a good learning experience. But here's Marty Neist, who arrived without, because there are no paramedics, she arrived with a tongue in her back in her throat. She wasn't breathing. She was apparently dead. And we took a film of her femur, and here's her kind of comminuted fracture of the proximal third of the femur. This is a poor film, of course. When you go back years and years, you don't always get exactly what you want to reproduce. But she was in big trouble, and about 3 or 4 days along, she had, we had to keep her head down because with this thrashing in her femur, we had this traction on her femur to try to keep it in position. She was, had her chest and her head were down, which was bad for both her head injury and the fact that she had pneumonia now with a tracheostomy. The chief of surgery, the chief of neurosurgery and our attending Taylor and so forth had talked to the family and told them to prepare for the fact that she was very unlikely to live. So I come by as a chief resident who had recently learned to do closed femoral intramedullary nailing. I talked to the patient's family, and of course, you know, I was considerably younger, not that much younger than Taylor, but younger than these guys that had talked to him already, and said, I thought we could save her life if we would take her down and operate on her. Well, the only reason that worked is because the patients were told by everybody else that she wasn't going to survive, so they would grasp at any straw, as you would guess. So I took her down the next day and nailed her femur. And this is what we did. I can't find the post-op x-ray, but this is 3 months later showing that she's already healed, and it also shows obviously that she's still alive 3 months later. In fact, she was back in school, and one of the boyfriends that she had took care of her for a while. Later became a paramedic, and I remember giving a talk to the paramedics much later, and I mentioned this case, and he was just thrilled because he knew all about her. Anyway, she still calls me about twice a year. As you know, she was here a few years ago for our July program, but she raised a family. She's not, her brain never came back perfectly, and so she's not totally normal, but her kids are very bright. And she's worked with her husband and running a business. She's now 62 or so, and like I say, calls me twice a year just to say thanks a lot because I'm still here. Now, how could we apply the Marty Neist principles in the population at large? We needed to have a designated and committed hospital staff to apply emergency treatment, including early stable fixation of fractures, and a system for on-site stabilization and transportation of injured patients, in other words, paramedics. Well, there was something going on in another area at the same time. In 1968, which is when I did Marty Neist, Leonard Cobb was reading an article from England about stabilizing cardiac patients on site in Ireland, excuse me, and he thought maybe we should be doing that out of Harborview to get together with the fire department and develop a retrieval system for cardiac patients. So in order to do something like this, it kind of takes a village, as Hillary would say. So what I'm going to do is introduce the players, and we're going to, how do we deal with the other thing was happening, we were dealing with the end of the county hospital system. This is when Medicare came along, and we no longer had, Harborview had a guaranteed population of everybody who had no money. If you came to the hospital, you got a wallet biopsy, and if there was anything there, then you had to go somewhere else. If there was nothing there, we said, welcome, come in, we'll take care of you, which was really nice, by the way. We didn't have to document for billing. And then we said, but we needed to find a new role that was essentially then for the survival of Harborview, and as part in teaching and research at the university, becoming a trauma center was one of the ideas about how to solve this problem. So initiating the transformation, then Cobb, as I said, who again also started his role in 68, was working out how we get with a Chief Vickery to get the retrieval, and then Copus came along. By this time he was a resident in neurology. He's about 3 years behind me, I think. We had the similar thing. He was in the Navy like or in the Army, I think. Like I was in the Navy and had just came out of Northwestern Medical School, but was from Seattle. And he was a neurology resident working in the emergency room, interested in overdoses. So he convinced Cobb that maybe we should make it just a little bit bigger. Well, let's just have him pick up people that are overdosed and about to die as well. So then, in 1973, by that time they'd had a class or two, and they realized that what they found in the street was a lot of people that were severely injured, and they didn't know how to deal with them. So then they called me, and at that time I had just become the chief of orthopedics at Harborview, although as Dr. Gunn called it, it was called the orthopedist in chief, because he'd been there, and that was an English term for the guy who ran orthopedics. So Kopis asked me to help. And we had this very extensive paramedic program as distinct from EMT they'd started. And he asked me to set up a curriculum for training them. And since there was nothing about that, I worked with some of the older paramedics, one of whom was Hal Nolf, who was a great big bum, or sort of a brash sort of guy, who helped me figure out what their problems were. They had been told always that you splint them where they lie and bring them in. And he said, this is hellish difficulty. If you found somebody in the bottom of an elevator shaft and they're all in a crumple and they got open fractures or they got fractures and you're supposed to not move anything and somehow get them to the hospital, this is damn near impossible. So I said, well, let's change the rules. You'll have you pull all of these fractures into line and put them on a splint and bring them to the hospital that way. It'll be much easier. And they said, boy, that'll make our job tremendously easier. It made it a lot easier until they went to Overlake with one of these patients, and they'd pulled an open fracture back into the soft tissues, and they would get chewed out and ranted and threatened with every kind of suit and so forth, that these terrible things they'd done. So this worked out well for us because they brought all the open fractures to Harborview, so nobody gave them shit. So that worked out to be mutually helpful. Anyway, I'll just show you now some of the anyway, this fact that Clausen had gotten this I am nailing here by that time, and we had done them now for 5 years, was very helpful to the trauma center, because a lot of these major injured patients, one of their major things that kept them from moving was a femur fracture, and by then we'd gotten pretty good at I am nailing. Now I'll just show you some of the players in this group that helped get this all started. Len Cobb is still around Harborview reading, mostly just reading I think he might be retired now, but until a year or two ago, he was around reading EKGs and so forth. Michael Kopis, most of you know, or I hope most of you know. He was our head of the emergency services for almost 40 years at Harborview. Then people got down on him because he didn't want them to bring in a new emergency department and take over the emergency room, and he's kind of a wrassy devil to begin with. And so people got mad at him, and eventually he got relieved of his job of running the emergency room, and then also to some degree of the paramedics, although the paramedics are absolutely devoted to this guy. Gordon Vickery was the chief of the fire department, who was very involved at that time. He's another one of the players. And here's the two favorite paramedics of mine. On the left is Hal Nolf, who helped me decide how to line the patients to bring them in. And on the right is Patty Schultz, who worked as our one of the aides on the orthopedic floor for 2 or 3 years while she wanted desperately to be a paramedic. This is way back in 1985 or so. And she was only 5'3" and about 110 pounds, and she couldn't carry a big 180-pound fireman up a ladder. So while she was working for us, she bulked herself up, lifting weights, doing everything she could possibly do. And you can see what happened. She got herself into the fire department and then got herself to be a paramedic, and she's still there, doing great. This is the first class that we trained with this new techniques. This is Donald Gunn, who was trained in Britain. He's a Scot, trained in Britain, and he was the chief at Harborview from 68 to 73. And he didn't really like trauma too well. He thought he wanted to be a spine surgeon, and at 73 he went off to Swedish to be a spine surgeon with some of the well-known local spine surgeons, and left me to be the chief at Harborview. Now, I was appointed to do that by Van. Van Sitters is the most important guy in this whole story. He's 6'8", or he was, and he didn't care what anybody thought. If he thought something was the right thing to do, then he did it. Now, the orthopedics had started changing the whole culture of the way we taught at Harborview. The attendings were becoming involved with these high-tech surgeries that we had to do on multiply injured patients. But the general surgeons were not, and they would not. They were all from Hopkins, and they were convinced that the way to train people was that you had a public hospital, you put the residents there, and on Saturday you came over and told them what they did wrong. Well, Van Sitters thought it was time they changed that, but he couldn't talk them into doing it. So what did he do? He fired them. He fired the whole damn surgery department. And he brought in a new one. I thought he was wonderful, absolutely wonderful guy. It wasn't a uniform opinion. I'm sorry. This is the other guy that came along out of the military. Dr. Jetland was an administrator of Harborview during this period. He was another big, long, tall guy, very friendly and willing to make decisions. And instead of sending you around lots of new crap to do, a new something to do every week to take up your time, he wandered around the hospital and he'd come in and say, "What can I do for you? Any way I can help you?" Some of you that know that you recognize the difference in the old 6th floor where the offices are now with the railings on the side, and they were homemade railings, you know, like all the business or the commercial ones that are made now. One of the things he let me do was have the whole 6th floor of the hospital, and that didn't include the north end at that time, and design it the way I wanted. And one of the things I wanted was these rails, which put a guy out of work who used to be around fixing the holes in the plaster all day. And that cleared that up and let people walk. But anyway, he gave us the entire 6th floor so we could all be together and run a cohesive service. Harold Laws was the medical director, another guy very, very helpful. No bureaucracy, just what can I do to help you? I'm the medical director here, I'll help you do whatever you're doing. This was a wonderful sister system. And then we had a team that came along after Mr. Larry and I kind of ran most of this up until 1975. When Windquist was in residency, during this early 5 years between 69 and 75 or so, he actually did his internship, a medical internship in Dallas, but he loved IM nailing, so he came on the faculty, and then pretty soon Dick Zorn did, and they lasted until 1980. And even though the dean tried to be helpful, we couldn't keep him on with no salaries. But anyway, then we went to the rest of the block. The rest of the people on that 80 to 85 group were Dr. Bach, who you see there with Dr. Swinkowski, and Dr. Foster. These guys were absolutely fantastic, the group from 80 to 85. They had to be, because in that time I got drafted to be the department chairman, much against my better judgment, but at least I was left at Harborview, which the dean did for the first time. It had picked somebody that could be a chairman at Harborview. Then Clausen came along, just a picture of him, just introducing everybody. And then this is just to show you the half of a resident class of 1969, Dr. Toomey and myself. This is not a recent picture. Harborview in the 80s. Our peer group from Hanover, we found out about much later. You see in the back there, on the way up in the back, was the guy who was our lecturer last June. This is Dr. Charnley and Dr. Zwip and myself in front. I went there to operate with him a while and then brought Zwip back to be a fellow, and ever since then he's been the chief of surgery and foot surgery in Eastern Germany. I wonder where I'm going with all this. Of course, my advice is to associate yourself with the smartest and best people you can find and collaborate in a way that will accomplish something really worthwhile. What you should take away, your job is to sort through all the information presented to you and find what helps you most in solving your patient's problems. You need to be an astute observer and a patient and careful listener. When you've treated a patient, only careful, objective follow-up for a significant time will allow you to learn whether or not you are accurate in your diagnosis and provision and treatment. As you know, nothing ruins good results like real follow-up. My personal guidelines are: avoid being judgmental, avoid bias, think now and then, stop and think, understand nothing happens for no reason, start treatment by getting rid of the underlying cause wherever possible, and in foot and ankle patients, remember there's another side. General advice is never give advice unless asked. Total honesty is the best policy. Don't go where the money is. Don't put your family second. Don't neglect your personal health. Don't retire. And don't overstay your welcome. And finally, just the thanks to the person that's been backing me up for the last 30, 40 years by doing all the work that makes these pictures. I'm sorry for going over a little bit. Thank you very much.
Thank you, Dr. Hansen. That was fantastic. To round up our morning, we have Dr. Wagner. He was born in Philadelphia, Pennsylvania, and went to college at Trinity College, medical school in Temple University in Philadelphia. He did his internship at the Royal Victoria Hospital in Montreal, Quebec, and did his residency here at the University of Washington. Spine fellowship was completed at the University of Hong Kong, and he participated in the Navy in 74, 75. His career here at the University of Washington started about 2004, and he's been a clinical professor both in the orthopedic and neurosurgical departments and the director of the spine service at the University of Washington. Prior to that, he worked at Swedish and Overlake Hospital and has worked at all the University of Washington hospitals. He won the Resident Best Teacher Award here at the University of Washington Orthopedics. He's been a national responsibilities, including the Scoliosis Research Society Global Outreach Chairman, and has done an immense amount of international teaching and surgical mission work. You can see that he likes to spend time abroad. This was taken back in the 60s in Syria. I'd like to welcome Dr. Wagner back up to the stage.
We'll try to push through this pretty quickly. It's a great honor to be here. And I thought I'd talk about the people who have stepped in front of me and helped me have a great time in orthopedics. And I think that that's the theme. I broke my leg playing rugby in medical school, and this is Dr. Lockman from the Lockman test. He took care of me. He had so much fun taking care of me that I decided to go into orthopedics. And the person who made it all possible was Dr. Clausen, who accepted me here at this residency, and it's been a great ride since then. This is a little bit my history, but it's a little bit the people involved. This is Hong Kong in 1975 when I arrived. 1% of the population had active tuberculosis, so every 100th person. And so that became the theme of spine surgery, as Pott's disease was part of it. On the left is A.R. Hansen, who became certainly one of the internationally known people in orthopedics. He had actually come from Uruguay. He had been in England from Liverpool and then came to Hong Kong and set up this department. I was right there at the transition of these two people, and Dr. Arthur Yao actually became one of my real teachers as I came into spine surgery. This other thing that happened is that the hospital, Sandy Bay Hospital in Hong Kong, was the only hospital that was taking care of children, and there was a one-way gate into Hong Kong from China at that time. So every day, a whole trainload of TB and club feet and all the problems came into Hong Kong for us to take care of, and they couldn't return. So the Chinese were pretty smart about how to get rid of the disease. And this became the Hong Kong surgery, or for Pott's disease. It was an anterior approach, and people would clean out the tuberculosis, put in rib grafts, put them in a cast, keep them down for about 2 months, and then get them up, and they would be healed. So when I got there, I was a little bit like Dr. Hansen. I didn't believe everything, and I said, well, this lady's got a sinus, sinus, let's see if I can push that. Right there was draining on her back. And so I decided I'd inject it. And all of a sudden she was in a coughing fit. And this is the x-ray I got, because that sinus connected with all the bronchus of the lungs. And then this is what a lateral looks like. So now you see that you had this sinus went all the way up into her lungs, went all the way down around her kidneys. And I had learned a lot about tuberculosis in an instant, okay, because this is what draining sinuses and tuberculosis cause. And this is another example of a 23-year-old girl with a word named scrofulous, which I had to look up when I got there. But this was a drainage in her neck. So this was a whole, because the posterior drainage of tuberculosis comes out of the posterior triangle, and that became the approach of how you got to that part of the spine. So tuberculosis was teaching us the anatomical approaches. And that's what Hong Kong was really good at. This is, you can see a lot on this x-ray, and it's fun to show the resonance because there is a narrowing of this disc, but then there's this huge paravertebral abscess going all the way around that. And that's the way tuberculosis forms, and it's still the way we see infections of the spine. This was her neck. It's not a very good x-ray, but there's a very wide space between the vertebra and her trachea, as the British would say. This is a 33-year-old that we saw, and this is the way this tuberculosis would destroy the spine. This happens to be showing you all the fluid that collected around the kidneys on both sides. And this is the way we treated it a little bit later. When we started using the Harrington rods posteriorly and the rib graft in the front, we were able to maintain the angle of the spine, and we didn't fall into kyphosis, which was the problem in tuberculosis. So this is him post-op. Another great giant was John Moe, because he was looking at spinal deformity in this country, he was looking at scoliosis, and he was developing the brace. So most of us grew up knowing that there was a conservative management for the brace, and only this last year has it been reconfirmed that the brace is really effective for scoliosis and things. This is the man who recognized that rotation was probably the most important, and he developed this little simple scoliometer. And this is what the patient looks like with a right thoracic curve. This is the scoliometer that measured it, and this was the way screening occurred in scoliosis. And the nurses could do this and then refer patients to you. This became one of the greatest giants in spine deformity, Paul Harrington. He was a great basketball player and track star. This is him at an earlier age. And this is really telling you the story. But the story was that he felt that scoliosis came from abnormal growth, asymmetrical growth of the facet joints, and that he wanted to put a rod in, stop the disease, and then they wouldn't develop the severe scoliosis. But he ended up working in a polio center in Texas, and he made a lot of sketches. And this sketch is a very classic sketch that got referred to the FDA many, many times, because on the right was a screw, and the screw was sneaking its way into the spine surgery. And this was the kind of work he was doing with the Harrington rods, and basically these people always had a compression on this side and a distraction on the other side. And it wasn't without problems. Dr. James Tupper was a graduate here in 1964 or 5, and he became a senior partner for me. And this is the original Scoliosis Research Society that met. I don't know whether, let's see if I can. Only Ted Hansen would probably be able, and that's Marm Mullen in his wild young days in the Scoliosis Research Society. He was also, so there were 3 members of the original Scoliosis Research Society from Seattle, which was a huge disproportion to the rest of the country. Adolescent idiopathic scoliosis was treated with Harrington rods, and you can see the problem with single upper hooks. And so many residents spent many days trying to replace hooks that came loose, and it was a problem, and that's why they had to be casted. Dr. Hansen mentioned Dr. Donald Gunn, who was probably the surrogate father of many of us because he was just the perfect guy. Perfect guy. And he came here from Singapore. He had actually graduated from Edinburgh. He ended up in a parachute group into Burma during the Second World War, came out with hepatitis, and lived a whole life in one person. It was just wonderful. And he was very much aware of the anterior surgery that was being done in Asia, because Dwyer had started that, and that became a big chapter in spine surgery. This was a cable, and that cable would actually break, it turned out, about 20% of the time. So cables were not a good thing, and but it was the way it was being done. So the procedures during Dr. Gunn's time was to go front and back, and we would put in the anterior instrumentation, which you see on the right, and then the distraction and posteriorly. This is another famous person from the state of Washington, with George Bagby, who was invited to one of our grand rounds here, and he developed this BK cage. And this was very surreptitiously, because he found a bunch of horses that were running across a field and falling, and the veterinarians called him because they thought it was their knees. And he said, no, I think it's coming from their spine. And he did a myelogram CT scan, found out they had stenosis. He opened them up, and there was this big hole where in a horse where that disc is. And he tried to look around to see what he could fill it with, and he thought a 12-gauge shotgun shell would be the right thing. And he basically cut holes on the outside of it, put bone in, and stuck that in. And that became eventually the BK cage. So here he is, he and I are walking down the streets in Bangladesh. And I only show you that because when the company was sold for about $600 million, he got some share of it. And he built a hospital, and he's a very famous person in Bangladesh, and I've worked in that hospital several times. Probably one of the most famous contributors to orthopedics is Dr. Roy Camille, who did it all. In the 60s and 70s, he dissected as an anatomist the cervical spine and the lumbar spine, and he did all the approaches, learned everything, and he is the first person to ever have put in a screw, and he did it in April of 1966. He wrote me a letter personally about this, and I've met him. He's now dead, but I knew him very well. And this is the story of a 17-year-old girl who came to the hospital when Judet didn't want any more spine on the service in Paris. And he took her down to the operating room and pulled on her and realized he had sort of realigned the spine in this paraplegic girl. He took a plate and put that plate on. These are personal communications with him. And the only plate he had was this plate. It was a Sherman plate, and it had fixed holes. And he laid it on the spine, he drilled and put screws in, but he remembered which screws seemed to have the biggest bite. 3 days later, he took an x-ray, and he realized it was down the pedicle, and that's how it happened. So he was just a keen observer, and things happen like that in orthopedics. So a lucky day for a trained observer is really a serendipity. And I pointed out to him that he wasn't the inventor of the screw, and I wrote a paper on the first screw, and this is the first screw that was ever used by Archimedes. It wasn't used to fasten, it was used to draw water out of the Nile. And it wasn't until actually the 1400s when it was actually used as a fastener, and it was used to hold the gun sights on because they kept getting loose with nails. And that's when the screw began. And then there's a great history of how it all developed and the threading and the heads and all the different parts. This is Art Steffi on the right and Heineck on the left. This was what Steffi contributed. Instead of having, this is the original picture of the plate, but this VSP was variable screw placement. So instead of having fixed screws, he could slide it up and down this slot and find the right place. These were the screws. They had an integrated nut that would be in here, and then you could run out the back. There were many studies that were done and these are classic, and they were done to show you the size of this, the width of this pedicle. But this was the problem. Some people were putting the screws in sideways. Some of them were breaking. This was the problem. So I thought that I would try to show you this is wrong.
Delano Las Vegas will bring South Beach chic to the Las Vegas Strip.
So this is something you may have all heard about. It's the 2020 famous show that came on. And this was...
it's a fact that 80% of us will have...
Barbara Walters is on the right. I am in the crowd being interviewed.
Some of those with serious pain, there is a surgical treatment using back screws. Every year, tens of thousands of people have these screws surgically implanted into their spines. But a 2020 investigation has uncovered some shocking facts about this technique that have never been reported before.
Well, first, the FDA says that these back screws are experimental. Patients don't know that, and the results can be disastrous. Now, how can this happen when they are being used by doctors and hospitals across the country? And isn't the government supposed to protect us from this kind of risk? Tonight, Dr. Timothy Johnson investigates these important questions.
Lake Charles is a town of 76,000 people in southwest Louisiana.
So I'm not going to show the whole thing. That was what tipped off a $100 million suit against us. We had started a small company in Ohio with Dr. Steffi, and we had taught around the country ways to do this. But Dr. Steffi had been rebuked by the FDA because they said that pedicle screws were dangerous. He said, no, it's just a bone screw. And he put the same screws in different parts of the body just to show them that. And then he used them in the pedicle. So there was a great argument between the FDA and Dr. Steffi. And this, there was a class suit across the country, and this was the $100 million suit that basically Johnson & Johnson eventually bought. So that's how that whole story occurred. And I don't have time to go into it very much here, but I will try to keep going here. This was another group that responded to that, and this is Mark Asher on the side, and he was responsible for a lot of the Zola stuff. And this was the bigger group that was really churning through all of the screw industry. I had 330 suits against me, and not one of them was my patient. It was just because I had taught the procedure. So that's the kind of problem you get with the FDA. 2 months after that suit was settled, the FDA agreed it was the best anchor in the spine. So the lawyers made a lot of money, and so you can see how it gets reversed. This was the first case of the Steffi screws put in, and it was done on, and I did it in December of 1985, and I think it's the first one done west of Cleveland. And there's been a great career around spine surgery, which we use every day, and it's the pedicle screws. So I'm going to skip through, but this was where we came to the osteotomies. Again, we're very late, so I was going to show a little bit how that's all done. These were the high-grade spondylolisthesis that we had no treatment for until we had pedicle screws. And these were the reduction. And so this is a gal who then came to us with an unfixable problem. But with the screws and with the rods, we really had tools to do it. This is what she looked like. This is, on the right, is my finger underneath the spinal cord as we resected the body which had been involved with tuberculosis. And this is the way we hooked it up. And there was her x-ray down to 38 degrees, I think was it. This is her. This was a 12-year follow-up. And that was great. Here's Paul. I'm going to go on. Paul Anderson was another faculty member here. And he worked with Majal and the others, and they really redesigned the lateral mass screws, which are used worldwide now, and certainly all of you are seeing them on a regular basis. Finally, this is a little bit of the future. This is a girl who came from England with a very deformed back after a surgery. And we can now get 3D modeling, which I think is a fantastic way to go. And it's available, it's reasonably inexpensive, and it's wonderful to take it home the night before and have it in the operating room right on your Mayo stand, and you'll be amazed how much fun surgery can be if you really have that. This is her after the corrected surgery. These are the kind of models you can make. This is the way we all live. We start, we stand up, we follow forward. That's something we have to work with. We can bend the rods, but it may not be the right thing for the patient all the time. My advice to this group is that this is the group that now needs to make footprints. This is one of my great pictures on the wall. What day is it? Ask Pooh. It's today. Squeak Piglet. My favorite day said Pooh. And that's the way I sort of feel about orthopedics and how much fun I've had with it. So you guys got to go out and make some footsteps and leave some footprints. Thank you.
Thank you for everybody coming. One more round of applause for the three wise men. Thank you all for coming. I thought that was a great morning. We'll see you again next month. We're happy to take any questions for any of the presenters.
was looking around, I did not see a single cell phone or electronic device come out this morning, which I think says a lot. And attendance was great. We have some great speakers too. As Dane said, we have 2 of our former residents coming for Grand Rounds this year who have really had spectacular early careers. Bert Yaze in spine surgery, who Dr. Wagner knows very well. And then Greg Nicandri, who is off to an incredible academic career at University of Rochester, is coming. And just the other night, Dane and I convinced Tom Green, who recently retired, to come and give us Grand Rounds on professionalism next July. And so we will try to keep these entertaining and involve the community and our former residents, and we will soon be on the search for 3 more wise people for the next one of these Grand Rounds. So thank you. Thank you, Dane, too.